morning, everyone, and afternoon, or almost afternoon. We're joining from all over the West region, including Hawaii, which is just fantastic. There you are, Lisa. Good to see you. Thank you all for joining us today. This is a second collaboration between the Pacific AIDS Education Training Center and the Denver Prevention Training Center. And we wanted to host some important conversations about what's going on for our patients and communities during this COVID-19 pandemic. So today we're focusing on behavioral and substance use considerations for those living with HIV, or I'll say patients with HIV in the time of COVID-19. Again, I am Bev Wasserman. I'm going to be your facilitator today. I'm with the Denver Prevention Training Center. I'm the nurse field consultant. I've spent many years in the HIV field. I was a clinician for about 17 years in our HIV clinic. So, and I'm currently an educator and assistance provider. So I'm really excited to be here and facilitate this conversation today with some amazing subject experts who are going to share some of their experiences with you as well. Again, I will just briefly say our objective today is really to discuss behavioral, substance use disorder, and housing-related services for persons with HIV in the context of COVID-19, discuss challenges and innovative practices in management of underserved populations, again, during this pandemic, and really share and brainstorm resources. So our subject experts are going to share their perspective, their experience, but we'd also like to hear from you about your experiences, your perspectives, what you're seeing in the field right now. So we'll all learn from each other. So very quickly, I'll ask our colleagues at the Pacific AIDS Education Training Center to introduce themselves. Brian, and I'm not sure if Jadon has joined us, but would you introduce yourself?
Sure. Good morning, everybody. My name is Brian Abascal. I'm a project manager at the Pacific AIDS Education and Training Center, and hopefully soon we'll be joined by our Deputy Director, Jadon Wright. She's having some Zoom update issues, which many of you joining today may have had to go through yourselves to join the room. So what we are is we're a member of the National AIDS Education and Training Center network of 8 regional and 2 national centers cover all 50 states. And we work to expand the number and the ability of healthcare professionals and organizations in the Pacific region, which is California, Arizona, Nevada, Hawaii, and the Pacific U.S. islands, U.S. affiliated islands, I should say. We work with healthcare providers, clinics, health jurisdictions, and policymakers in the area, and to bring you training, capacity building, technical assistance in HIV-related topics and services. So that's all I'll say for now.
Great, thank you, Brian. Ty, would you like to say a little bit about the Denver Prevention Training Center?
Yes, good afternoon, everyone. My name is Ty Edward Few. Can everyone hear me? Yes, great. I am the manager of our Capacity Building Assistance Program, and we are funded by the Centers for Disease Control and Prevention to provide free capacity building assistance services to agencies working with people who are HIV positive and those who are doing HIV testing in clinical settings. And we are very happy to be a co-sponsor for this afternoon's webinar.
Right, thank you, Ty. We also have, the only way we can pull off these wonderful virtual meetings is our staff at the Denver PTC that help us host events like this. So we've got Misty Gutierrez, who's our SEBA administrator, who's helping us today. And then you're going to hear a little bit from Victoria Myers, who's our distance learning coordinator. So Victoria is going to give us a little tech check and reminder, and she and Misty are also here if you need help. So she will talk to you a little bit about the technology today.
Thank you, Bev. Well, welcome everyone. It seems like everyone has got the mute button down, but if you do want to ask a question once we get to our question time, There's a little button down in your lower left corner that says unmute. You can click that to unmute and ask us a question. We do ask that you stay muted until you are speaking, just to make sure that we're not having any sort of feedback, or we can hear what's going on at your house, since most of us are at home. But know that we would love to hear you. You're also welcome to use the chat box, which we've had a few people chat in as well. I'll go ahead and type here. That's where the chat is. If you have questions throughout, you're also welcome to chat in there. We do have some moderators that are going to help us, so Ty and Jadon, once she gets on. Some of the other functions are your video. We would love to see your faces. You can tell we're all on camera, so we would love you all to be on camera. You can just hit start video, which is right next to your unmute button. If you're on the phone, I'm sorry we can't see you, but you can unmute by clicking *6, so just so you don't forget that. And make sure everyone is renamed to your first and last name. That is so we can take attendance. If for some reason it is not your first and last name in here, you can hover over your own picture box or find your name in the participant list. Click it, there's 3 little dots, and then you'll hit rename. Finally, I will get to the views. So we have gallery view and speaker view. Up in the top right corner, you'll either see what I call Hollywood squares or the Brady Bunch squares. You can click that to see all the different faces that are on, or you can click speaker view, and that will make whoever's talking the bigger screen on your computer. And we will also do some polling. So that is a feature you'll see that will pop up on your screen. Sometimes it doesn't load for folks just because of the bandwidth. So we'll make sure you can type your chat in the chat box as well for that. That is all I have. Please chat me or Misty if you have any questions on tech.
All right, thank you, Victoria. Excuse me. Thank you. So one thing I want to do before we get started, I want to let you know who's joining us today, and you're going to hear from each of them in just a moment. We want to thank our subject experts again for taking time to join and share their experience with us today. So we've got Lisa Ravel from the Harm Reduction Action Center in Denver, Colorado. And then Dr. Hermione Hurley, there she is. She's also in Denver, Colorado. Dr. Kathleen Clannon is from Alameda County in Oakland, California. And then Dr. Glenn San Agustin from JWCH Institute, Inc. in Los Angeles, California. And then Dr. Christina Wang from Hawaii and the Health and Harm Reduction Action Center in Honolulu. So again, we have representation across the West region, and we're really happy and excited to hear from them. So before we get started, we're going to set up our first polling question. How many of you work directly with patients who are, and you can choose all that apply to you, people who are experiencing houselessness or homelessness, people with substance use disorder, people with HIV, people living with a mental illness.
I'll give it just a couple more seconds. We've got about 70 people have voted percent. So. Hopefully you all can see those results on your screen.
Okay, so as we assumed, we're in like company, right? These are the populations and communities that we all serve and we care about. These are people we care about. Today, I guess Victoria, I'll let you pull that. Are you able to stop sharing that screen?
Yep, it stopped, so it'll pop off in a second.
Okay, great, thank you. So again, we're in like company. I want to acknowledge each of you for the work that you're doing and have been doing for our communities. And we know there is a lot going on in our nation right now that again calls us to more of what we already believe in and we care about. So I just want to acknowledge each of you and remind you to take care of yourself during this challenging time, not only around COVID, but all the things going on in the nation. So again, on to our fantastic presenters. As I've shared with you all where they're coming from, but they'll tell you a little bit about their organization, the population they work with, and we'll ask them to share a little bit about, you know, what adaptations have had to occur based on COVID-19 with mental health and other medication access, all these factors that have to be adapted during COVID-19, and in particular, any involvement with housing strategies, having to create hoteling spaces, respite. What's the impact of people being relocated during police sweeps? I know we've had that in Denver happen quite a bit. And ultimately, what are your big challenges and what are the solutions you all have come up with? So I'm going to ask Lisa Ravel to share a little bit about her perspective with us from the Harm Reduction Action Center in Denver.
Thank you so much for having me today. My name is Lisa Ravel. I'm the Executive Director of the Harm Reduction Action Center. We're Colorado's largest public health agency that works specifically with people who inject drugs. So as you can imagine, we have been very busy these past 9-10 weeks. 76% of our folks are homeless or transitionally housed upon intake. So if you can remember 8 to 10 weeks ago when everything was changing daily, most of their factual information about COVID was being talked to them by HRAC staff members. A lot of folks who are unhoused don't have access to social media or the news, and with things changing so quickly, it's important they have the right information. We've also seen that many of these service providers have abbreviated their services, which we totally understand. Ours are abbreviated right now as well. But what we're really lacking down here in downtown is food options for folks. So some of the food, the like already prepackaged meal food that folks were having access to have not been operating for the last at least 5 weeks. So a lot of folks are very concerned. We also have the Denver Public Library is closed. That's the largest day shelter in this part of town. So we have been continuing, we've been trying to give out snacks for folks. The Colorado Criminal Justice Reform Coalition is buying our participants breakfast burritos 3 times a week. They're really hearty in the morning, and that's sometimes the only food source that folks have during the day. We continue to get the questions of when is it going to be over? It's like, I fucking know, right? So we're trying to make sure that folks have that factual information. We're giving out the masks. And then as you can imagine, since like last Wednesday or Thursday, we've done a lot of street outreach in the area about the protests happening too. Much of it is in Civic Center and up and down Broadway, where a lot of unhoused folks have lived for years. So we wanted to make sure that they had good information, knowing it wasn't just one night, it'd be multiple nights, having the masks on, having water, making alternative, if you don't want to participate, making alternative places where you can go for safety. They had no idea the first night what was going on. And so, you know, just kind of having those conversations with folks too. So I can't believe it's June 1st, and I can't believe we've only had COVID since March. But it's just been, every day has been very anxious for folks, and we are seeing a small percentage of relapse, newly unemployed, folks that have anxiety, and just trying to figure out what next month is going to look like and what next year is going to look like. I don't know if I hit everything. I just was like, ah.
You did, Lisa. That was great. I was just going to ask you, have you noticed any change in how people access substances, whatever their substance they use that you know, keeps them feeling comfortable, and you know what I mean by that.
Yeah. So we have 50% of our folks inject heroin upon intake, and about 50% inject meth. There is a lot of polysubstance use too. As you know, we have black tar heroin in Colorado, which is difficult to snort and expensive to smoke, so you almost have to exclusively inject it. There has not been a supply disruption at this time. However, we are starting to notice with folks and asking them even just late last week, what are you seeing? They're seeing things that are less pure and a little more expensive. That's the first that we had heard of that. I think the Denverite did an article quite a few weeks ago and said drugs were very difficult to obtain. That is not true. We're busier than ever. But that is a thing that national colleagues are looking at too, of like what service disruption would look like for people. Now, I don't have many people that are interested in treatment right now, in that there's a lot of self-medication that's happening and they can't get IDs. The DMV just now opened up the appointments and things like that. We know Denver Health does a nice job of trying to get folks in, but also people are very nervous about being on hospital campuses right now too. And what we're really seeing is a lack of access to bathrooms, which is where if you're homeless or transitionally housed, you inject. So now we're seeing more public injecting in alleys and in parks because they don't have access to the library or business bathrooms. And so we're concerned because we know that fentanyl is here. We had triple the overdose deaths in Denver in 2019 than we did in 2018 that were fentanyl related. But it's very difficult to check to see if your drugs have fentanyl or fentanyl analogs in them if you're behind a dumpster. So we continue to have those conversations about supervised use sites and taking injecting out of the public sphere, but I know that a lot of people are seeing it more in the downtown area because they don't have the bathroom access that they did before. And bathroom access in general, even washing your hands with soap and water. I mean, much of the messaging that's come out has been stay the fuck at home, which you can if you have a home. Wash your hands with soap and water, very difficult if you don't have running water. So a lot of times people are trying to, being dismissive about everything because it's like, well, I don't have any of that. And it's like, well, here's what we can help you with.
Well, thank you, Lisa. That was, I mean, you pretty much laid out the whole perspective about all these things we recommend from kind of the, middle class lens of, oh, everybody has, I mean, even we're finding, just the whole social distancing or being able to isolate in your own home. If I live in a home with multiple generations of family, that's not really realistic. So again, you share a lot about access and, how important it is. And I hope this will also be an opportunity for us to, work on some of these issues around, drug use, safe drug use sites and things like that, where now all of a sudden people are aware, like, oh, people are out here using because they can't go anywhere.
Right.
Yeah. All right. Thank you so much. So I'm going to move on to, did someone have a question? I thought I heard. No. Okay. All right. So we're going to have another speaker present who will align nicely with what Lisa just shared with us. Dr. Hermione Hurley is from the Denver Health and Hospital System, and she works with patients, in particular patients with HIV, substance use disorder, and or mental health conditions. So Dr. Hurley, share a little bit about your perspective on this topic as well.
Well, hello everyone. This is my best American accent. Anyone who's ever kind of heard me speak knows that I don't sound very American, but I'm speaking slower than I used to. I'm a Kiwi, so apologies if I sound a bit funny. I'll try and slow down. But so my role is kind of an overlap role. I'm a provider and a physician in infectious disease and also addiction medicine. And I'm a neighbor of Lisa. I work on the campus of Denver Health, but we're just a few blocks away. So I am like I am a provider who does mostly outpatient now. I work in a Ryan White clinic where I have a patient panel of people living with HIV. And then I also work in our hub and our spoke, which is the outpatient behavioral health services. I'm not sure if anyone can see me right at the moment. I'm not sure if it's triggering me or someone else. But if you can hear me, wave your hands around and I'll keep talking. All right, thanks for the hand wave. Okay, I'll keep going. So really, to me, this feels like an epidemic of substance use disorder wrapped in a pandemic of COVID, on top of the structural inequity of racism and social determinants of health. And so what we see is that people who have a little more resilience have a little more reserve to call upon, and people with less resilience, or say less supports in the community, are having a much harder time. And that strikes for us this incredible diversity in how we have to be able to respond. So we did a lot of things around COVID, and some of them we did really fast. And honestly, we just hoped we were doing good and not harm. So one of the most fastest things we did was in mid-March, when the state and federal governments allowed us to liberate the doses of methadone. We made the biggest changes in take-home methadone doses than we have ever done in the history, we think. So if you were previously coming 6 or 7 times a week, we said you can only come 3 times a week. If you had at least reached even one stage of our phases in recovery, we would say, okay, let's get a week. And if you were medically vulnerable, we tried to be as liberal as we possibly could in our take-home doses. As we were doing this, we were very aware and concerned. We hoped we were not causing unintended harm. And I'm here to tell you, I don't think we did. So we've been closely monitoring takeouts, closely monitoring overdoses and use of naloxone. And there are increases, but our clients overwhelmingly have supported more liberal dosing in terms of their takeouts, especially as it has been more and more difficult for people to travel on public transport. As the RTD gets closed down, we're under a curfew state at the moment, and my clients are getting dropped off blocks away from getting to the clinic. So we halved the number of times you had to come to the clinic. We took our daily attendance from 400 to 200 a day. And we introduced social distancing almost overnight. This was particularly stigmatizing for a number of our clients. It felt really hard for them to feel like they were being asked to wear masks, they were being asked about symptoms, and they didn't always find that comfortable. But what they told us in no uncertain terms was their family were very concerned about them having to come to campus frequently. They were very concerned about having to come to campus regularly. And putting in safeguards early made it so that our clients could say, hey, they're taking it very seriously. They're giving me a mask. They're taking my temperature. They've got room in the floor so I can safely wait. And if I'm unwell, they will deliver my doses to the door or to the car, or they will try and courier me my medicines. In terms of buprenorphine, we were able to do telehealth intakes and telehealth follow-up. So we were able to rapidly be able to do those over a phone. Now, I would say we have 600 people in our opioid treatment program, so in our dispensing program, and about another 600 who are in our prescription or outpatient program who don't necessarily have to come for medicines. We overnight went from no telehealth to 60 or 70% of telehealth. That did not suit everyone. Many of our clients didn't have telephones. They felt the real difficulty of not being able to come and get a daily structure. So we maintained a very strong presence. We regarded that we were going to be essential. We talked about as crisis services, and we really tried to act more like an urgent care for people's needs as they came in. What am I seeing in terms of trends? Well, I'm seeing a trend that COVID came mostly from the community into my clients, not my clients bringing it into the clinic. So the first people amongst our clinic to get COVID positive, and I don't think this was just because of testing, I really believe it was because of a trend, it came from staff. It came from clinic people who were able to travel and have widespread contact with people. You know, before we called about social distancing in terms of infection, my clients were subject to social distancing from everyone. You know, people socially distanced from my clients forever. So, I mean, this was not a new concept to people who are vulnerable in my clinic. So in some ways, I think my clients who have HIV or a substance use disorder or are seeking treatment are the subject of another sort of wave of things that came to them last, not them first. So that's what I'm really trying to do. We kept some missions in our head, we wanted no wrong door. We're a part of a hub and spoke treatment system, and it was hard for people to feel confident that they could attend the psych emergency services or the ED to start Suboxone. That did not feel like a safe portal for them anymore. What we found was we had a slight uptick in methadone walk-ins, not a huge one, but a slight uptick, and we became a low barrier methadone clinic, a slightly higher barrier buprenorphine clinic. So we were doing a lot more over the telephone for people who were able to for buprenorphine, and we're starting to see some increase in requests for methadone. 3 or 4 months ago, I was like 15–20% of our dispensed medicine would have been Suboxone, and 80% would have been methadone. Now I'm 90% methadone, 10% Suboxone. So to me, that means that people are still getting care, but we have a double trend here. We have a need to maintain services for people who are already seeking treatment, and we're starting to see some new needs. You know, what I'm honestly seeing, and we measure temperatures and symptoms at the door, and we have a partnership for curbside testing for COVID. I've now tested about 150 out of our 600 people who come. I'm sort of about 20 or 30 people COVID positive. So that of the people with symptoms who I test, I'm about 17 to 20% of positives. But what I'm really finding is that it's the non-COVID issues that are really starting to hurt people. Trust is huge. Now we went from a situation of people being tight and sort of self-isolating to an increasing level where my clients are subject to violence. I'm seeing an increase in domestic violence amongst where my clients are subject to rapes, to violence, to difficulties in maintaining self-housing, to family members who may have accepted them back for a short period into a house, to saying, hey, it's too risky for me to come and let you come and stay with us. And so I'm finding that actually some of my clients are even more on the street and less into shelters. Fear and isolation seems to be really big issues, not just amongst our clients, but amongst our staff. So what were our strategies? First of all, we acknowledged that fear and we acknowledged that loss of control. And what did that look like? It looked like daily huddles amongst our staff members. Really supporting staff members to be flexible in how they worked, trying to maintain equipment for staff members so they could work at home, being really liberal in our use of cabs, Ubers, and trying to even open some hours and the number of hours we're open because the RTD abruptly closes and people can't actually get here on the buses. We're trying very hard to support partnerships. Our harm reduction center, trying to spread expertise into our residential facilities, because a lot of our treatment programs have not felt safe to be able to open and re-accept people seeking treatment into residential facilities. We're advocating, and we're advocating hard. Lisa and I were both part of a group where we did a critical standard of care. It's like an emergency plan. That we used COVID as a model, but it was about how we could support and then at times compel an increase in services across our state. And that's gone to the through our state public health to state government as possibly a model for how we can try and maintain services, especially in rural areas or in low staffing areas. And I really would strike a note here that says, please look out for your community workers. I feel like some of the greatest skills that we could lose as a result of this are not for the likes of me. I'm probably going to be employed forever, sadly, but I do worry that some of our most vulnerable colleagues in the community are most vulnerable to job loss, are least likely return into outreach services or peer or people with lived experience services because they're least likely to be able to maintain if they're furloughed or without an ability to be able to be paid. So we've got a lot going on. I'm hopeful, but I'm really nervous that we've moved from the COVID causing the greatest chaos now to the social and racial inequities causing the greatest problems now. And I am really worried and struggling to keep people into hospital or into clinic for really urgent non-COVID needs. That's me.
Thank you, Dr. Hurley. That was tremendous. We're getting a bigger picture again about how people access services or not, and and your challenges you had building trust in this new dynamic, keeping structure for folks that really need that, to know that if I go here, this is what's going to happen and who's going to be here and how things are going to work. And just the little things like people being able to access telehealth or telemedicine. Again, Lisa mentioned the library being closed. If that's where you use the computer, then that's no longer available too. So we're kind of starting to paint this picture of the huge challenge this pandemic has created in this particular community, and layering on the issues around racism and inequities and all of that. So we do have a question in the chat box here for you, asking about what trends you've noticed in communities with substance use, mental health, or housing related issues. What trends have you all noticed? And we'll let you all respond in the chat box.
And thank you, Bev, and as you type in your responses throughout the conversation, I will read the chat box and present what's going on there, so that you don't have to try to monitor the chat and listen to the presenters at the same time.
Okay. I'm going to ask Victoria, I think we have another polling question as well. So put your question, we already got it up. Are you noticing cultural barriers as a particular challenge to providing care for those seeking substance use and mental health services during the pandemic? And we have several options there to choose. Language, essential workers, unable to access culturally relevant services, mixed messaging from community leaders, or other. Please feel free to write other ideas in the chat box.
I'll go ahead and give it about 6 more seconds if people want to click on their answers. And the results should be showing on your screen. If they're not, they will in a second. And after the fact, you all can, if it doesn't disappear on your screen on its own, you can exit out of it.
Okay, it looks like the biggest, the largest group we have here is the socially based communities not able to meet, of course. When we talk about our communities who are living in, are houseless, and that their community is out in a space that's now suddenly unable to be accessed, even being able to use bathrooms, things like that, being able to use the library, it becomes a particular challenge. We also note that there's a lot of, which this whole pandemic has been a lot of mixed messaging, right, from really around the world. I think from the nature of a pandemic like this, and that there's various perspectives politically and socially and all these different things. So thank you all for responding. And we've got a big shout out about misinformation, right? So again, we either are getting different perspectives and we're getting misinformation, and there's just a lack of resources as well.
There's also a question in the chat box, an increase in the number of individuals who had stopped using substances and re-engaging in those, or people who are living with HIV who were adherent, but now are not adherent due to depression or other COVID-related factors. So if you have heard things like that, or are you witnessing that in your practice, type it in the chat box and we're here to talk about it.
And we are part of the community. I'm sure if you're thinking about your time since March 5th or whenever this started to creep up in the U.S., it has been stressful. And it has been really stressful. So yeah, we're seeing relapses, we're seeing more alcohol use. So I will move on now to Dr. Kathleen Clannon from Alameda County. Tell us a little bit about Oakland and your work and what you're seeing.
Hi, everybody. Well, I just wanted to start out by acknowledging how it's a heavy-hearted moment, and just you know, thinking about the murder of George Floyd and where our country is right now, it's hard, but it's actually feeling great to me to be able to see all of us here together to try to advance some things. But I just felt like I wanted to say that to start. So I am the medical director for the County of Alameda, which includes the cities of Oakland and Berkeley. And I'm an HIV specialist doctor, and that's my practice, but mostly I've been working in the area of homelessness and whole person care. So Alameda County has a lot of people experiencing homelessness, including a lot of people with HIV who are homeless. Our PIT count from 2019 showed 8,000 people across the county, which probably means it's more like 12,000 humans, really, because we don't count them all. When COVID began, we were really struggling because we didn't have places for people to go. So we could give them a lot of help in terms of navigation, of housing navigation, but didn't have places to navigate them to. It was really a soul-crushing piece of work, both for the clients and for the people working with them, to try to keep everybody's heart up. And I think part of the weirdness of COVID is the way that it brings sadness and risk and promise all at once. And our strategy of relentless incrementalism, the step-by-step, whatever it takes to solve these problems, suddenly we've been able to zoom forward like a rocket ship on a few things that were never possible before. So in terms of COVID in our county, and specifically in homeless people, you know, California has done pretty well, relatively speaking. We've had 3,000 cases altogether in our county. And of those, 68 people are HUD homeless. So it's a small number so far as we know, knock on wood. We've had 7 outbreaks that in either shelters or in encampments so far that we have closed, that we contained and closed. There's 6 active outbreaks now, a mix of shelters and encampments. And one of the things that we've done, which is both good and bad, is to have a lot of street medicine capability, 7 different teams with different composition that have been going out. They've had to essentially completely reorient their work, which used to be about getting people into substance use treatment, a lot of help, you know, around housing, but also getting people on buprenorphine, getting them into mental health treatment. Essentially, the street medicine teams have pivoted now to do almost all COVID work. And what that looks like is they screen people in the encampments. We have about 400 encampments with 3 or more people in them across the county. So they're running around like maniacs right now, supporting encampments in being able to socially distance, working on food delivery to them. And where there is an outbreak in particular, we have a really well worked out containment set of strategies that involves bringing food, talking to people, remonitoring, going by every day. And I have that protocol, by the way, that I could share with anybody who wants it. So how to, the COVID containment in an encampment steps. We're all doing the same things, it's hard to write it down. So it's hard to find it someplace. So, so that's a lot of our work has pivoted to containing outbreaks, which we've been doing pretty well. But it does mean that some other things have been neglected. So the part where we're suddenly zooming ahead like a rocket ship is that we have been adopted a strategy of isolation and quarantine hotels. So we have about 600 people now, formerly homeless, who are in 4 different hotels. And we also have we have more coming. We're trying to get to about 1,500 people We are specifically target, anybody who has HIV is among the people that we are flagging and trying to get into our the hotels, but it's just anybody that has any kind of medical fragility. And that is a really interesting, means that we suddenly got a whole bunch of people inside and really made it clear to me that housing first is not just a phrase, that when it's stressful in a lot of ways for people in the hotels, moving them out of wherever they were into this literally isolate. I mean, they're there to isolate. So it's literally isolating. That's been challenging, but because we have behavioral health on site, we're doing tele-psych, we're doing tele-buke, we're doing, support with peers, all of those things we're able to bring to bear to people who are bored out of their gourds, sitting in their hotel rooms, watching TV and answering their room phone when one of our people call. We also have been able to push the limits very, very far on our harm reduction. We're working with the methadone programs, are delivering doses to the hotels. We had to do a lot of stuff to make that possible. We also have, it's wet housing. We have a medically managed alcohol program. So people are actually prescribed and given alcohol. And if they've indicated that would be a reason that they would withdraw, or that would be a reason that they would leave isolation, we do that only for the COVID positive folks in the the quarantine hotels, not in the safer ground ones. But that has been amazing stuff I never thought we would get to in my lifetime. And that is being endorsed by a local government and the state in order to be able to do. So that's been kind of the promise part. In terms of the cultural pieces, there are some cultures that where people find it more difficult. The idea of being in the hotel is harder than others, and there's mixing. People haven't been able to kind of withdraw into their usual communities. It's a forced community essentially that's really self-organizing from nothing. And self-organizing a community from nothing when you can't talk to people without a mask on and can't get closer than 6 feet. Turns out that's challenging for us as humans to establish new friendships when you're in quarantine. So we have a culturally affirmative practice is our model. It's been really interesting to me to see, as a medical provider, for sure, our medical providers are not a particularly diverse group, and in particular African American or African descended, but it's more diverse for sure than the housing community. I don't know if you guys have seen this also, but now as I'm engaging more with our folks who work around the issue of homelessness and housing, it's really, really white, at least out here in California. And so there's a lot of, the how to sort of acknowledge that, and the fact that African descended people, African Americans and Africans, make up half of our homeless numbers when they're only about 12% of the population. All of that has been, how do we grapple with that, and how do we actually be leaning into culture as a way that people need their culture right now in order to be able to get through this experience. So we're struggling with that, but have mostly leaned into peers and publications and other kinds of art and things that help to support people. We're really big on genograms. So having people tell their story as part of their treatment and their care. When they are coming into the hotels, we have been connecting with people and asking them to tell the story of their family. When did your family, migrate to California? All kinds of stuff that helps people kind of helping to ground people and remind them that they're part of a bigger story. That this event is a huge part of that, but is part of what the scope of where you come from and how it shapes you. I think I'm getting pretty much done there. The last thing I want to mention is that as part of our whole person care project, one of the things that we put in place was a community health record, which is it's a data platform that brings together housing information, the medical information, jail census. Now it has, if people are located in a hotel, it has that. It will have their COVID test results. That's been a tough sell in the HIV world because we're so reflexively, concerned about disclosure and, and stigma. But we are certainly seeing that the ability to look at that right now makes it possible for us to provide care to people if they get caught up in a sweep, or if they come into the hotel. Then the different members of their team that are working with them can all see, what's happening at the same time. And we can, as soon as people show up, if they get sick and they show up at an ED or something, we're able to immediately see that, and then make sure that we have someone at the hospital to pluck them out and bring them to the hotel if they in the specially equipped isolation van, if they'll agree to come. So moving from the relentless incrementalism to the rocket ship has been complicated. Pretty much we've been using the proceed until apprehended motto at the moment. And there's been a lot of flexibility and a lot of county council not paying as much attention. So, we get a lot of stuff done by informal partnership instead of having to have MOUs that take forever and are not worth the paper they're written on anyway, as all of us know. So that's been kind of cool. And we're all just scared about how far the virus is going to go in our communities. And we're scared about how long it'll last, our ability to support these new interventions. And just to close out around the dangers of this, we actually lost a guest at one of the hotels. She hung herself in her room. She had come to us from a drug treatment program. So she was 90 days clean and sober, and then was in a sober residence. And there was an outbreak at the residence. So she came to us to quarantine. The day before, she was going to go back to that sober residence, where again, she would not have been alone. She wouldn't come to her door. So they broke the door down in the hotel and found her dead. So it's been a very, very heavy few days thinking about that and about, the danger. We felt good about bringing her into safety from the virus, but part of me feels that she would not be dead today if she had stayed in her residence with her community. So, it's very strange days, a mixture of risk and sadness and promise. Is what it looks like from here. That's it for me. Thank you.
Thank you, Dr. Clinton, for sharing. You are absolutely right. There's so many intense feelings and things going on, and then you describe another consequence of this whole situation with COVID-19, kind of unexpected, unintended, that people will not just die from the virus, but they might die really from the upset of the balance in their lives. So thank you for sharing the story of whole person care and acknowledging that there's hope, that there's some good things that happened by you all being able to dose patients and clients with alcohol if they needed it, if it was going to be the cause of them leaving, being able to dose methadone, the way Dr. Hurley also described, like being able to shift these things. And again, hopefully we're able to hold on to some of the things we find are effective and were needed long ago. But now we have this opportunity to move forward in the rocket ship, like you said, Dr. Clinton, just blast out these different strategies and really hoping for the best. But sometimes in a situation like this, we have to act and kind of look back and say, well, what part of that do we want to keep, or do we want to keep all of it? So I think, Ty, do you have a question for everyone?
Yeah, I put a question in the chat box about any unique adaptations made for people with HIV requiring behavioral and substance services during COVID. We've already had a couple of responses regarding they had to abbreviate their social drop-in hours, but there's been some additions to their kits that they're giving out. Thank you, Lisa, for that. We also had a question come in from one of the participants. And I'm going to read this question, and this would be great for a little bit of a discussion. The question is, are you seeing shortages or changes in the underground substance market? Are shortages causing issues with clients going through withdrawals from substances like opioids? What support options are there for folks who don't want to stop using? I felt that was a really great question that we could take a minute or two to discuss before we get back to our presenters.
Can I just say that I'm not seeing shortages so much as cautions about people not being sure that they want to go out into the normal places where they might be able to get substances or work with someone who they see normally in the community. But I am seeing expense. So I am seeing it being harder and more expensive maybe to get substances, and lots of alcohol. Lots and lots of alcohol, which I think is a lower barrier. So in my clinic, in the Ryan White Clinic, primarily I see clients whose substances of overuse are more likely to be alcohol and methamphetamine than they are to be opioids. And so I think some of the ways that people in the past have used methamphetamine as part of intimacy or sexual relationships or alcohol has really increased. So those are the places that I'm seeing a really big change in my practice.
Yeah, and someone else said that, Dr. Hurley, that there's been a lot of increase in alcohol usage as well. We had a comment come in from Christina, and she will speak later on, but that there was a fear of shortages, which caused people to learn about rehab and detox programs, and that was a positive aspect for engagement. Bev, back to you.
Remember our mayor announced with an hour's notice that he was going to close the liquor stores, and we had this huge rush. I mean, like every liquor store in Denver just suddenly packed with people. And so we advocated very strongly to say, you know, reform is good for alcohol, but it's not going to happen in 2 hours. So can you just please regard actually both marijuana and alcohol retailers as someone who shouldn't be closed down, because we were really concerned we were just going to see a significant number of people detoxing or withdrawing and needing hospital services. So it was kind of our equivalent of the kind of closing the borders and everyone rushed to a place that we would have wished they didn't rush to. But I think the mayor heard that and reversed it within a couple of hours.
Within a couple of hours, yes, there was a change. And, you know, as people are dealing with life in a pandemic, but also life under structural and institutionalized racism and oppression, I can see why there is an increase in substance use. Bev, back to you. I took over a little bit, but that was in the chat box.
Bev, I think you're muted on your cell phone.
I'm gonna say we know this is not the time to detox our whole society from alcohol. It's not a good idea. So we're gonna move on now to Dr. Glenn San Augustine from JWCH Institute in Los Angeles. Dr. Glenn, please share your perspective, what you're seeing, what adaptations you've had to make as well. We're happy to hear from you.
Hi, can you hear me?
We cannot. 1 second. Let me. All right, try that now, Glenn.
Okay, thank you, Victoria. Hi, good afternoon, everybody. I'm speaking from the perspective of Los Angeles. I'm an infectious disease and HIV specialist in Los Angeles. Our agency is called JWCH Institute. We have over a dozen clinics all across LA County, and our primary flagship clinic is located in Skid Row. With respect to patients or persons living with HIV, we serve over 600 every year. And specifically to our Skid Row clinic, about 60% of our clients are homeless or housing is unstable. So we definitely specialize in that, and we recognize the inherent disparities and inequities that face our HIV homeless patients. In fact, I actually pulled up some numbers specific to our HIV and homeless. So across our agency, we have a viral suppression number of about 68%. That mirrors LA County viral suppression numbers. It's estimated right now about 65%. For our Skid Row patients who are living with HIV and are homeless, our viral suppression rate is 51%. So as has been mentioned already by Dr. Hurley and Dr. Clannon, housing is fundamental to achieving viral suppression for our HIV patients. And we recognize this, and we recognize the added complexity of COVID-19 on top of that. And so we knew that this is an area that we excelled in already as an agency, but we knew that we were going to need to face some new struggles during this time. So in order to respond to that, we worked very closely with our public health department, with whom we have a very close relationship. There's a division of HIV and STD programs within public health. And then we worked also with the mayor's office. And what we did there is we provided testing across at least 4 of our locations for COVID. This was an open invitation for testing. We, in fact, reached out to local shelters to provide this added testing. And then on top of that, we worked closely with our county hospital to ensure that patients who are being discharged from the hospital are going to be adequately housed. So we mobilized some of our units to provide services within a hotel. And we also opened up a COVID unit within one of our recuperative care centers. So in terms of creating services and options for our unhoused patients, we definitely tried to stay ahead of the game on that. One of the things that really came out during this time, and it was a big learning experience for me and for our agency, is our mental health support. It remains stable, but the need exponentially increased. And so a lot of our patients who are living with HIV with concomitant mental health really entered into a world of uncontrolled symptoms. So we've had several instances where it became very violent within our clinic. It was a threat to both our staff and our other patients. And we've had to respond to that both in the immediate sense, where we had to call the police, but we also needed to reevaluate what were the services that we needed and that we were lacking. After I spoke with our mental health team, we didn't actually hold our mental health services, but a lot of them, as other agencies did, is we shifted over to telehealth for mental health and across our services also. But this is still a learning experience for us. We're trying to identify where it is that we're actually lacking, but that is, in my opinion, one of the biggest things that came out during this time is this subpopulation of comorbid HIV and mental health really were severely and disproportionately affected by COVID-19. Let's see what I wanted to talk about. So I want to speak from 2 different angles here. So we have our Skid Row clinic, who are 51% virally suppressed. Almost 2/3 of them are homeless. That is one sort of population that we have under our care. But I also manage our clinic in East Hollywood, where there is a lower proportion of persons experiencing homelessness. But in this in this world, it's a little bit of a different story. It's kind of a tale of two cities. In this side of the city, we have a little bit more of a better control of HIV. We have a little bit higher proportion of patients who are virally suppressed. Sorry, I think my video cut out, but I think you can still hear my audio. Here, it's interesting, and I want to bring in, I don't think it's been mentioned yet, but sexually transmitted infections, in my experience, has been on the rise. Prevention as well as the pre-exposure and practice. And I'm seeing an uptick in syphilis and gonorrhea, which we knew was already high, at least within our MSM population. So I just want to draw attention to that, and that there is, one group of people who are sheltering in place, but there are others who I think are coping with the stress of COVID by engaging in higher risk sexual activity. So I've noticed, at least anecdotally, an increase in that. And lastly, I want to mention that we have had to put on hold some of our services, our outreach services to our nearby commercial sex venues and bathhouses. We typically outreach there at least once a week. We provide on-site HIV and STD testing. That program is on hold right now, and we're just kind of waiting for the Department of Public Health to give us the green light on when we can reopen those services. Many of our staff are furloughed, and so, we were already on the brink of being very short-staffed, but even more so today. And so I think that does have some trickling down effect on our patient care. So overall, I would say we tried to stay ahead of what we anticipated was going to be the impact of COVID, but unfortunately, the disproportionate impact is, at least what I'm seeing, is among our mental health patients. Who are just, I don't want to say forgotten, but I think we don't have the resources that I think they need at this time. So that's all I got.
Thank you so much, Dr. Sam Augustine, for sharing your perspective and your story from Los Angeles. And I'm going to make sure I wasn't muted again. And acknowledging, even the difficulty you all had with violence in your clinic, which really highlighted that, the resources for mental health services were not there. And we all struggle with this from time to time. But again, I think this pandemic has pushed us it's pushed everything into the light that we could before kind of not have to address. I thank you also for reminding us about STIs. We know, at least from our clinic in Denver, we've had to reduce those services significantly. We know that's happening all over the country. And also it has to do with people's coping. We might, use substances. We might have a little more sex. We might have sex with people we hadn't been having sex with. So all those things, of course, can create risks that weren't there before. Let's see here. Are we doing another poll? Is it time for another poll? I just saw one popped up. Okay. Okay, there we go. Has access to services increased or decreased during the COVID-19 pandemic? And I think I might know the answer to this.
Are you asking about access or demand, Bev?
That's a good question. I think we were speaking about access. But demand is another question. Because it sounds like what we've heard so far, we've had an increased demand, definitely. Okay, so most folks look like it's decreased. Some have stayed the same, and a little bit more has increased because we have adapted. I know one thing we've seen from the whole telehealth revolution is that some clinics have been able to engage, not necessarily HIV specific clinics, but some clinics have been able to see a large population of patients that they sometimes in the past didn't have access to because people had a phone or they had access to a computer and they were stuck at home. So guess what? They showed up for their visit. so that's kind of the upside to telehealth if people have access. So let's move on to Dr. Wang from the Health and Harm Reduction Center in Honolulu, Hawaii. We're done with this poll, right?
Correct. I don't know why it popped back up.
Oh, that's okay. So Christina, share your story from Hawaii and what's going on there and what are you all doing. Nice to have you.
Aloha, folks. It's 9 a.m. in Honolulu, so we're still in our morning. Thank you for inviting us to share what's happening in our islands. I think a lot of the trends that we've already spoken about are very similar here. I will point out we have not had any homeless COVID positives in Hawaii, except for one individual that tested positive on Maui who actually went into Maui Memorial for a non-COVID related issue and unfortunately contracted COVID in the hospital. So in terms of our homeless community in downtown Honolulu, particularly where we have the majority of our houseless unsheltered, we have not seen outbreaks. And I would pivot that to talk about kind of some of the things we've done here locally. So just to give folks a background, I'm the medical director and I'm an adult geriatric nurse practitioner here at Hawaii Health and Harm Reduction Center. We're a nonprofit agency that has a newer name, but we've been around for 25 years. We were co-located with two nonprofit clinics. One was the Life Foundation, which was our AIDS support AIDS support organization arm, where we service about 700 clients living with HIV/AIDS, and we receive a lot of Ryan White support. And then we have the community health outreach work to prevent AIDS component. That was our syringe exchange arm for the state. So we are located on almost all the islands as well for our syringe exchange program. So then recently to kind of pivot to the times of COVID, I was appointed by Hawaii Department of Health to be the medical director for our new temporary quarantine and isolation center, which we started March 1, very abruptly because we were basically expecting to be a New York situation because of the number of homeless that we have in Hawaii. We still particularly remain very high in the number of homeless per capita nationwide. And I was impressed that someone referenced their point in time results. So I too went and tried to pull our point in time that's not actually quite published for this year, but the draft numbers are showing about 4,429 people experiencing homelessness on January 22nd for point in time here in Honolulu. So that number is certainly not exactly representative. We have definitely more because we have even seen an uptick in the number of people that are coming to Honolulu that are houseless by flights, even though we've had reduction in travel services to Hawaii and strict mandates around quarantine. So the temporary quarantine and isolation center was set up just for this. This is folks that are houseless that would have normally been, isolated or quarantined in their home, but because they don't have that access, we have brought these folks to our center. And the criteria, of course, is that either these are people that are symptomatic, needing testing and isolation, or these are folks that we've received as warm handoffs from the emergency rooms and hospitals that have already been tested and are awaiting their results. But are safe for discharge to the community. So we've been managing both the COVID symptomatology, although we're very fortunate that we have not had any COVID positive at our center to date. But we've also been doing all the behavioral health and substance use component, as many folks have mentioned. So we've been doing detox management on site. We are a facility that's not a wet shelter. So that has been difficult. We actually do not have wet shelters on the island of Oahu. So folks that have come we've been very fortunate to utilize our CSACs and our social work resources to help engage people through motivational interviewing for them to understand, you know, what's available to them during this time. And one thing I mentioned earlier in the chat box was that because there was a fear of people not being able to access substances that they preferred, then we saw a transition in interest of learning more about detox programs and what residential treatment centers were available. Residential treatment centers actually became of interest to folks that wanted a respite from the streets because the streets have uptick in violence here, as well as just kind of chaos because services have been cut off in the community, such as like their normal churches that they may go to for food and engagement, or libraries, as were mentioned. I do run a street medicine program twice a week, so we utilize advanced wound care in street medicine as a way to engage our folks across the continuum. So we work on an acute need and then expand out into utilizing other access and resources like primary care or HIV management or PrEP. We also run a buprenorphine clinic, and so we have seen an uptick in interest and inductions of buprenorphine. We've been doing them via telemedicine, although I'd say even though that's a newer service for us and we're expanding in that role, it's still more challenging for us because I remind folks all the time in Honolulu, particularly our lovely emergency rooms that discharge people right back to the park, that they have no phone or computer lab there. So that's not going to work. So we have to get creative and really go out to where people are. So we have not cut down as an agency on our outreach services at all, although some of our community partners did need to reduce their outreach services. And one would be particularly that our state-funded HIV clinic reduced their services substantially and then actually closed. So we've had a decline in the number of persons receiving STI testing and treatment. And as other folks mentioned, we have seen the rise of gonorrhea, chlamydia, and syphilis. So that's been a challenge. I would say we've actually had a slight bump in people who are interested in re-engaging around their HIV medication management, which has been really wonderful to see that. And that may have also been on the backs of the fact that the state decided through the MedQuest division to help get medications dispensed for a larger quantity for longer doses, which was really nice. And I think that other clinics and providers really had to reduce the barriers that they had set up, like forcing people to come in for so much medication management. And we saw that through our methadone programs. We saw increased in take-home doses. We were actually able to work with our Honolulu Police Department in their initiative, which is called the POST, which stands for the Provisional Outdoor Screening and Testing. And this was an area for people who were houseless but had no symptomatology of COVID. They were able to go and actually go to a park where there's individual tents set up and isolate there and receive some medical services and screening. And so we really had to coordinate that effort between the methadone clinics and going to this provisional isolation center out in the park, because people were not able to then leave the post to go get their methadone daily. They actually had to quarantine and isolate for 14 days there. And there's kind of a triage system that the police department has set up where they move from one isolation center to another after they've already quarantined for 14 days and shown no symptomatology. Ironically, in the same breath of talking about police, we've seen an uptick in the number of folks arrested through sweeps. We had a very brief reprieve from what Honolulu has notoriously called compassionate disruption that we are just not supporters of. It goes against a lot of evidence-based guidelines on this, and we've seen an increase in our cell block numbers. I have two other providers with me at this clinic, one who actually works at cell block 5 days a week. So she sees, roughly about 90 patients a day in cell block, where they have a very difficult time practicing social distancing, where they may have 4 people to a cell and not enough masks and not enough hand hygiene access. Similarly, other folks have mentioned the bathroom challenges. We set up in Honolulu a coalition called the Bathroom Brigade, and these are folks that have just banded together to help train people who live in the parks how to take care and keep their bathroom clean. They've actually gone and stocked the bathrooms with soap and toilet paper and necessary supplies, and they hang a sign outside of the bathroom letting them know that the bathroom brigade will be helping them and servicing these areas. But it was a real challenge for the month of March. We fought and fought with our local legislative to reopen the bathrooms. We really engaged with our ACLU on this issue, and really told our legislators, please utilize best practices through CDC and the National Homeless Council on this issue, that we could really face an outbreak of hepatitis A if we close all the bathrooms and people are utilizing the streets for bathroom access and no longer have access to washing their hands. And similarly, that takes away kind of the area where people are using substances. So we are seeing substance use more in the public eye, and that's brought a significant challenges to particularly our downtown Chinatown area, because we get a lot of pushback from City Council on substance use and what it is for the importance of syringe exchange access. So I think that's kind of what we're doing in a nutshell. It harks on similar trends and things that people have already mentioned. So thank you, and I'd be happy to take questions from the Honolulu group.
Thank you so much. Thank you for sharing another layer of perspective and also some opportunities. You spoke about engaging with police departments, engaging with city council politicians, having them understand these needs, that yes, this does affect the public health. So there again, another public health issue, that if we don't provide bathrooms or have a way for people to use the bathroom or wash their hands, then everyone's impacted, very much like COVID. It's like we're all impacted if we can't have masks, if we can't have services. So
we're actually utilizing our temporary quarantine and isolation center as a proof of concept for crisis stabilization in the state. It's something we don't have crisis stabilization beds, and since more than 60% of our folks that have utilized our services at the temporary quarantine and isolation center have either been actively withdrawing and detoxing on our facility or needed very significant behavioral health and mental health support. We're really using this to show statewide the need for that, what we're calling the Goldilocks effect, where they're not, too sick to be in the ER and in the inpatient side. They don't meet that criteria, but they are way too sick to remain on our streets, and we really need that intermediate respite area.
Yeah, definitely.
Well,
go ahead, Ty.
Say that in the chat box, we've had a lot of action going on. We put a question in there about, are there cultural norms that you've seen or observed that assist in keeping communities safe? And we've had a couple of answers to that. Dr. Hurley talked about moving to a 90-day refill for meds and also using delivery services for meds. Also, Dr. Hurley said that there was, but on a case-by-case basis, delivery of Sunoxanol to clients who are COVID positive. Also, door-to-door controlled substances like MAT is also new as well. What other sorts of adaptations or cultural norms are you seeing out there in your communities that you can share during this time? And don't be shy. We have shared a lot during this time as well. And if they're not cultural norms, if there are other things that you have on your mind, people have shared so many times on this particular webinar about the fear of using public transportation to try to get around and how that's impacting their ability to access care and get meds. What else are you seeing in your communities?
We've definitely had trouble with the IDs, as other people mentioned. So obtaining people's disability bus pass has been a real challenge. And so to augment that, we have definitely increased utilization of our Lyft and Uber medical services. But I am concerned about funding for that and wish to continue that, because as we all know in this practice, that transportation is such a barrier to care.
Yeah, transportation, that distance to care is a major issue. We also have someone sharing that they've seen an uptick from a pharmacy perspective, an uptick in e-prescribed prescriptions compared to those usually written, alongside with an uptake of 90-day authorizations from both the insurers and insurance companies and prescribers. So that's also there. The Children's Hospital in Colorado has attempted to get approval for 90-day fills as well and moved to telehealth visits.
So a lot went down in LA last night. We watched it from our house here.
Oh, okay. I thought we were going to hear something about LA. So yes, there are a lot of adaptations happening, a lot of ways that we are moving to meet the needs of our clients using technology, but there are also, different challenges that we are facing. Also, this particular population that we are talking about is the population that is also currently adversely affected by the social and cultural institutionalized racism that is happening. All of the protesting that's happening is impacting our cultural trauma and mental health on some level. So we need to keep that in mind as well. We have someone saying that the stay-at-home order was lifted in mid-May in Arizona, and the public was against it. Public transportation has been free in Tucson since March, and they have shifted to home delivery of almost all services, food, prescriptions, as well. In Northern Nevada, we are hearing that there is delivery for pharmacy and food directly to patients who are in their home and need that. And each delivery, they are also providing safe sex kits, complete with condoms, lube, and information on IPV as well. So,
Ty, did you want to talk briefly about the changes that were already started but accelerated, like the self-test for GC and chlamydia at home?
Go ahead.
And there was the mail out for home HIV testing, so that meant effectively you could do remote PrEP maintenance for screening for both GC, chlamydia, and HIV. Obviously, it's a little harder to put a urine sample in the mail, but the swabs actually were there, and a lot of those initiatives were already being started. And I just think, like one of the other presenters, accelerated to try and help people stay at home and maintain on PrEP.
Yeah, I think that we are seeing definitely from the CDC side, there is an uptick, and definitely thinking about how we can move out home testing for HIV and STIs into the public right now, how to effectively use telehealth to reach not just populations who are distant to care, but populations right now who are still sheltering in place or just not ready to come back into the public sphere, because we've been sheltering in place for 11 weeks or 10 weeks now. And this is real. People are really dealing with life. And in 140 cities, there have been protests, and each city looks like a war zone. So people are nervous about going out to the public. So we are facing a problem or facing an opportunity as people are needing more, or as we are experiencing collective trauma. There's going to be an uptick in the need to discuss how that's impacting other aspects of our health and care.
Could I just say one other thing about housing? We were really grateful that we were able to do a physically distanced shelter. So we went into some of these really big shelters and in our big sort of well, we have a huge agricultural show usually filled with bulls and ducks and all manner of things. So we didn't have that this year, but we used that as one of our physically distinct shelters for men and a physically distancing shelter for women. We're now doing surveillance to try and see how much COVID is in the shelters. I'm really grateful that you don't have COVID in your shelters in Honolulu, and I'm kind of jealous because some of the initial screening that we've done, even in small numbers, shows more like 25% of the clients that we had COVID, and of those, only a few percent had symptoms. So we are really thinking that COVID shelters are places where asymptomatic individuals are having a tough time. Then our homeless coalition, a Colorado Coalition for the Homeless, and a lot of state and public agencies are doing a great job to get individual motels for our vulnerably housed people with COVID positive or COVID likely. We faced increasing difficulties delivering methadone doses to those clients. At times, we actually started to worry that we were making them more vulnerable by identifying them in places where our nurses turned up in full PPE with bags of methadone and handed them to a motel door. That wasn't always safe for our clients. We found it was okay for some of our male clients, but increasingly our women do not want to go to those shelters because they feel increasingly unsupervised and concerning. And so in fact, I think there's some movements in our state to try and have a more supervised environment, a little more like a nursing kind of supported unit rather than individual motel rooms, because there was increasing amounts of, not everyone was subject to violence, but it felt increasingly difficult for vulnerable clients to go to those places. So it kind of feels like homelessness and vulnerable housing is a big lift to solve at the same time. And I think a variety of solutions is what's really helped. Outreach into community for people who don't want to go to a shelter, physically distancing the shelters that you have, some individual rooms for people who don't necessarily feel safe in a larger environment, and then other people feel more safe in a monitored environment. But I think, you know, we're building the plane as we're flying the plane kind of feeling through all of this. Yeah. And I think some of those social determinants are becoming a lot more prominent in our state.
Thank you, Dr. Hurley. Definitely we need any and every idea, creative idea to address all of the social determinants we're faced with. So we're almost at the end of our...
Oh, can I sneak in one question? Anyone got good models of contact tracing for people who are housing vulnerable? I mean, contact tracing feels like a great idea if you go to 3 places and you live in a house, but it feels like very difficult for people who have large social networks, don't have a telephone. Is anyone doing contact tracing well for vulnerable population?
We're doing it. In terms of well, I suppose either we've been lucky or we're doing it well because we haven't had large outbreaks. So I'll send along we have an environmental scan and a protocol for the contact tracing that I'll send to Brian.
Thank you.
Thank you. So Jadon, I believe you had some announcements. Did you have an announcement or two?
Actually, I'm going to introduce Tom Donahoe from the LA area, a Pacific Gate Education Training Center, who I believe is on. I think he had an announcement about some future work. Tom, are you?
Yeah.
Okay, great.
Yeah, I'm working with Dr. Brian Gardner, and we have sort of a 3-phase project that is going, and I don't know if Brian Gardner's on as well, and if he's able to comment, where we did a survey of planning councils and HIV, substance use disorder treatment organizations and AIDS service organizations to see which substance use disorders were most likely to cause an undetectable viral load in patients. There's a lot of variance regionally. We're currently surveying people to see which evidence-based interventions they think are most feasible in their area. And then in the 3rd phase, we'll be offering TA to different HIV service organizations and clinics. And so If people are interested in that, let Brian know, and Brian can let me know as we approach the third phase. Thanks, Jadon.
No worries.
Okay, well, I want to say a huge thank you to all of our subject experts who presented and told their stories from their community perspective. I think I know I learned a ton, and these ideas are what we can feed back into our own work, our own communities, and continue, because this is a constant learning for all of us. So we really, really thank you for joining us today. We're planning another collaborative meeting like this, where we're going to dig into disparities and equity and these topics that are right at the forefront of our work, as it always has been, but now more than ever, we have this impetus to move forward with making change. So again, thank you to all of our presenters. Thank you to our colleagues at the Pacific AIDS Education Training Center. We always enjoy working with you. And everyone, take good care of your body, your mind, and your spirit, and be well and be safe.